folic acid for MTHFR is not even the appropriate thing, or B12, not even the appropriate thing to do in the grand scheme of things. It's so minuscule. If you're not sure if you need to be evaluating homocysteine and things like that for methylation, here are some of the signs and symptoms that you can start to see in your patients that can key you into, maybe I need to go a bit more down that rabbit hole. Fatty liver disease is, there's a large portion of patients who are deficient in phosphatidylcholine because of methyl cycle defects that then result in the inability to export triglycerides, or I should say a decreased ability of the ability to export triglycerides out of the liver, leading to fatty liver disease. There's some animal models in these genetic models where simply just giving them enough choline actually greatly improves their fatty liver disease. Okay, so methylation is important in that. Obviously, an elevated homocysteine. The bolded ones are the ones that kind of are a stronger indicator for me to dig a bit deeper. Running a homocysteine is standard. If I'm doing a stem cell procedure and I'm doing pre-lab work, a homocysteine is standard, whether or not they have fatty liver disease or any other anemia, because I still just want to know what we're dealing with before we go and do anything. And then obviously our macrocytic or megaloblastic anemia, even if we're trending, which I think labs, we're trending on the higher end, okay? So when we look at MCV, MCH, those two seem to increase first before the MCHC does, hence why those values are a little bit higher to me in terms of the test value. But when I start to see this creep up towards the higher end, so if a patient walks in, they're not anemic, but their MCV is 96, their MCH is 33, that's trending towards that higher end. Warrants looking into. Remember, it's not a cliff. You don't have an MCV of 97.9 and then you hit 98 and all of a sudden you're B12 deficient. You're B12 deficient that whole time. It just wasn't fully showing in the other parameters that we're looking at, okay? So in terms of methylation stuff, the big ones I'm looking at is I'm running a CBC and a CMP, which is going to give us our red blood cell parameters there and our liver function tests. Liver function tests there's two ways you can look at it. One way is if it's not elevated, you don't have to look at it. I would probably disagree with that. The way I would frame it up is this. So 15 years ago, the reference range for ALT and AST used to be this. Less than 20 for a male, less than 15 for a female. Why would a lab reference range change? Population change. What's happening to our population? Obesity and fatty liver disease. Okay? If my patients are above this, I don't say you have fatty liver disease, because again, that's not how we look at our functional lab testing. It just keys me into, do they have fatty liver disease that is not being picked up yet because their ALT isn't 80. Okay? Things that are going to help here are going to be the things that, in terms of that, are your liver detox herbs, right? Milk thistle, dandelion, that kind of stuff can be helpful. But what I would probably, bigger is going to be phosphatidylcholine and fasting and changing their diet. Okay? RBC folate, serum folate, and serum B12. So serum folate is going to fall first before RBC folate does. So that's a little bit more sensitive, hence why its test value is medium. A little bit more sensitive to alterations in folate status. In terms of B12, you can have a full-blown cellular B12 deficiency and your blood test looks 100% normal. Because you can have genetic polymorphisms in the transport of B12 into the cell. So B12 in the blood looks great, but it's not getting into the cell. Hence why I rarely look at that unless I'm really scratching my head and I'm doing we're looking at, a NutriVal through Genova, which is going to be looking at both blood and urine metabolites of vitamins and minerals. Okay. Oh wow, it's right there. Look at that. So this is the basic testing that we're going to do for methylation. If I need to do a little bit more in-depth testing with my patients for methylation, I'm doing something like Genova's NutriVal, which is going to be both urine and plasma, and it's going to look at a lot of different things, but the main things in terms of methylation that we're looking at is going to be B vitamins, our minerals, and antioxidants. Additionally, we can look at some functional genetic testing. Okay, so this here is a new software that I've been using. Honestly, it's been like 4 weeks or so that I've been using it, but I'm really fascinated with it. What it does is it takes our genetic data from whether it's 23andMe or they have their own kit, which is a bit better set up to look at some of the other SNPs, such as things like NAD and whatnot. But it breaks it down into categories saying that, hey, maybe this is something you should look at. Okay, this is mine here. So the big things for me, this got cut off at the top, but my ability to handle folate, vitamin A and D, glutathione and NAD, and then I thought there was one more on choline, but my choline status is terrible. But something like this can give you some more in-depth look at what might be going on to then correlate that with what is actually going on in terms of clinical symptoms, okay? You have to be really careful to not use any of this as diagnosis.